Hello everyone, my name is Kyori Kim, and I'm one of the social media section editors of the Archives of Plastic Surgery. I'm excited to introduce Hot of the Press. Twice a month, we'll be hosting Hot of the Press with one of the authors of the latest APS paper and two panelists. It offers you a special opportunity to directly hear from the authors and join an insightful discussion between panelists. You can also leave your thoughts as a comment for further discussion. Hello everyone, I'm Kyori Kim, one of the social media section editor of the Archives of Plastic Surgery. Welcome to the Hot of the Press. Today's article is Current Concept of the Surgery First Orthognathic Approach, which is published in the March issue of 2021. Here we have Dr. Jong-Woo Choi from Assam Medical Center, who is one of the authors of this article, and Dr. James Bradley from Northwell Health as a panelist. And we have Dr. Min-Jung Cho from MD Anderson Cancer Center. Let's start with Dr. Choi's presentation.
Dear my fellow doctors, my name is Jong-Woo Choi from Assam Medical Center, Seoul, South Korea. Today, for about 7 minutes, I will briefly review my concept and surgery first approach. Based on my recent review article of the Archives Plastic Surgery, we will discuss about the current concept of the surgery first orthognathic approach. So compared to the conventional orthognathic surgery, in surgery first approach, we do perform the orthognathic surgery before the orthodontic treatment. Meanwhile, the traditional orthognathic surgery consists of pre-surgical orthodontic treatment for about 12 to 18 months, and it is followed by the orthognathic surgery and post-surgical orthodontic treatment for about 6 to 12 months. It takes a long time to complete whole process. However, as the patient continues to masticate, the perfect decompensation is not that easy. So in surgery first approach, given the fact that the main etiology of the dentofacial deformity would be the skeletal discrepancy, and the symptom of the dentofacial deformity would be the dental malocclusion, let's correct the skeletal discrepancy first, probably, and then the post-surgical orthodontic treatment can be more efficient. Is it functional? Given the fact that the direction of the teeth movement in post-surgical orthodontic treatment would be identical to that of the natural dental compensation, it can be regarded as a functional one. Let's take a look at these pictures. Compared to the pre-op natural dental compensation in class 3 patients, after the orthognathic surgery, without the post-surgical orthodontic treatment, the natural dental compensation can be used efficiency of the post-surgical orthodontic treatment, like the figure B. However, the problem is how could we solve the occlusal instability during the post-surgical orthodontic treatment? To my knowledge, there were 3 ways to solve this problem. Firstly, active use of the miniscrew. Secondly, the regional axillary phenomenon. Thirdly, the use of the natural dental compensation. In 2010, Dr. Sugawara group in Japan published the surgery first, the case report based on mostly active use of miniscrew, including the intrusion of the molar teeth and shaving of the teeth for avoiding interference. Meanwhile, Dr. Eric Liu and Yu-Rui Chen in Jianggung published the similar surgery first accelerated orthognathic surgery case series, mostly based on the regional axillary phenomenon. Finally, in 2002, one Korean orthodontic group named the Smile Again group already published the paper under the name of functional orthognathic surgery. It includes the novel laboratory work, such as the separation of the old teeth on the dental model after maxilla and mandible movement, which leads to the recreation of the surgery first status without pre-surgical orthodontic treatment. The core concept would be the direction of the orthodontic tooth movement would be identical that of the natural dental compensation, especially in post-surgical orthodontic treatment period. Based on cooperated with this orthodontic group, So since 2007, I started to apply the surgery first concept, and then I have been making the multiple publication about the surgery first orthognathic approach. So I will briefly introduce how I do the surgery first approach. This is the simple summary of the model setup. Traditional model mounting. Then if we separate all the teeth to mimic the actual pre-surgical orthodontic treatment, then orthodontic surgery will be done on the dental model. And then at this stage, if we change the dental teeth model into the original teeth model, we can get surgical model without pre-surgical orthodontic treatment on the model. So this is initial, immediately after the orthodontic surgery without pre-surgical orthodontic treatment. Definitely some open bite and interference exist, but 12 months and 19 months, we could finalize full treatments like this. So pre-op, immediate post-op, overall the bony and dental remodeling has been made. See, even 3-class patients, my earlier experiences with the pre-surgical orthodontic treatment, orthodontic surgery was done. The benefits and drawbacks of the surgery first approach is like this. Firstly, the goal of the pre-surgical orthodontic treatment is like this. You will know, you can refer to the paper, elimination or reduction of dental compensation and establishment of the horizontal and vertical position of the anterior teeth, canine and posterior teeth, and arch coordination and alignment. The drawback of the traditional orthodontic approach, as you can see the figure C, before the orthodontic surgery, the patient looks would be aggravated because of dental decompensation process during the pre-surgical orthodontic treatment. Advantages of the surgery first approach is actually includes these facts. Possibility of the total treatment time, no need of the aggravated growth appearance during the pre-surgical orthodontic treatment. It can be regarded as a patient-oriented surgeon-initiated approach and efficient, the timetable and early correction of sleep disorder. Likewise, the possible disadvantage of surgery first approach are like this. The time-consuming two-setup simulation for surgical occlusion, more delicate and complicated the surgical treatment objective, need for accurate and experienced decision-making regarding the possibility of the surgery first, the complicated wire banding, no possibility to extract the third molar before surgery, possible need for the extended period intermaxillary bony fixation, and then the incomplete lip and facial profile immediately after the surgery and chewing difficulty in the same period. The indication and contraindication, actually, we thought if the surgical occlusion in surgery first approach were conducted through the simulation, actually it can be applied to all surgical cases. However, we emphasized some possible contraindication may exist like this. We will discuss later. So main stability, we will discuss the stability issues, but in summary, in my experience, overall, while the skeletal, the stability were maintained, the dental pattern showed different the characteristics. So in summary, the overall, the skeletal stability turned out to be maintained in most reports, while the total treatment time can be minimized like this. So total treatment period in surgery first approach averaged 14.6 months compared to 22 months in conventional orthodontic first approach. We'll discuss issue as well, so I will not talk in the detail. In summary, the surgery first orthodontic approach can accelerate the orthodontic treatments and reduce the total treatment time. So it could be a paradigm shift, especially very stable in class 3 and facial asymmetry management, but it could be controversial in applying the class 2 or the syndromic patients. So I could conclude the surgery first orthodontic approach without pre-surgical orthodontic treatment turned out to be stable and applicable in the long term in many cases. So recently, I published the surgery first orthodontic approach by the Springer. So for the details, you can refer to my books. This is my summary of my article. From now on, we can discuss the details.
Thank you so much for your presentation. Let's move on to the discussion part. Anyone has questions?
Well, I want to first congratulate Dr. Choi and his group for the review article and also the book, which has helped us immensely. They've been doing, they mentioned 15 years, but I think they've had a strong influence on popularizing this technique throughout the world. And that this is a very traditional conservative group that does orthognathic surgery, especially in the US and even more in Europe. But through his publications, as you can see, it's really changed the way we look at things. So congratulations, first of all. My first question and discussion is, so you've been doing this for 15 years. Can you tell us how your approach has evolved over that time period, specifically on your indications, patient selection, technique you've done? So if you can just touch on how things have changed as you've adapted this technique.
From the beginning, the percentage of my surgery first approach would be less than 30% in my whole case. But recently, overall percentage of surgery first approach would be surpassed 70 or 75%. Actually, not at all. So especially in cleft or syndromic group, don't apply any surgery first approach for many ways. And then in technique wise, we are more applying the digital simulation in surgery first approach. But the difficulty is very time consuming. So we should separate all the teeth from the model, and then for mimicking the actual pre-surgical orthodontic treatments. So digitization actually additional time-consuming process. But actually, we are aiming at the fully computerized the surgery first approach program, but we didn't finalize program yet.
Thank you. In your article, you mentioned accelerated orthodontics or rapid orthodontics in patients that say need leveling or arch coordination or widening of the maxilla or aligning the arches. Can you discuss that? Obviously, you mentioned how decompensation is not necessary because the process of surgery will help with that. But can you discuss when you decide to use more of an accelerated orthodontics versus just going in with SFA?
The accelerate the orthodontic surgery, the term appeared on the paper. I think it would be related development of the mini screws. More and more the dentists or orthodontists are very good at using the mini screws. So compared to practice in the past 20 years ago, the orthodontists are very good at the use of the mini screw. So we could shorten the pre-surgical orthodontic treatment period. So not that perfectly remove the pre-surgical orthodontic treatment. Actually, sometimes at least 3 months or the 6 months, or sometimes the 2 months, the pre-surgical orthodontic treatment might be necessary. So we call it surgery first accelerate approach.
Great. Now in the US, obviously, important relationship between the orthodontist and the surgeon. And orthodontists here are using more and more Invisalign approach to all their patients, including orthognathic. So the Invisalign with regard to these patients and the use of, you mentioned mini screws, or we call TADs. Can you tell me how that's incorporated? Because we're starting to use that on all of our surgical patients. Have you seen that use in South Korea, and how does that incorporate into your process?
So you mean about the Invisalign?
Invisalign, right, for as opposed to traditional brackets and wires.
So actually, my orthodontist groups are actively using the Invisalign, so in post-surgical treatment period. But I think orthodontists need correct some degree of the tooth movement. Actually, they are using the mini screws for the impaction or rotation. So in that purpose, I think the mini screw would be more efficient compared to the Invisalign. But in many cases, I've seen the active use of Invisalign even in surgery first approach.
Great. And then you did mention what we call virtual planning, because review paper, you do show that your model surgery and the effort needed before surgery, but we're doing more and more, almost exclusively now, virtual planning for our cases. How does that fit into surgery first?
For the surgery first, the simulation, we can move and simulate the separate tooth for mimicking real pre-surgical orthodontic treatments. So in the wet lab, actually, we are very good at the controlling the tooth, but on the digital space, actually, we didn't make the not efficient yet. So I think we need to develop more efficient the computer software program for the surgery first.
I just had one more question. It's more of a technical question regarding to preparation for people that are just starting it. It was impressive you showed the cephalometric, both the horizontal and vertical changes were similar with and without SFA. But when you're assessing, part of the assessment preoperatively is looking at to come up with your vertical alignment. So patients that have, say, excessive overjet, how do you work in that the artistic part of assessing the optimal vertical height when you're dealing with surgery first patient?
In case of the class 3, actually, immediately after the orthognathic surgery, as you see, the overjet definitely happen. And then sometimes the posterior molar teeth has an early contact. It looks like open bite. We do not call it open bite. Actually, that after the remodeling of dental compensation in post-surgical treatment is an auto-rotation of mandible will be followed. But in order to overcome the incisor angle and vertical angle, actually, we are very emphasize the use of the occlusal plane altering orthodontic surgery. So maxilla should be rotated the anteriorly or posteriorly. That would be the reason why I love posterior maxillary impaction. So incisor angle can be controlled without the pre-surgical orthodontic treatment. And then height can be managed actual orthodontic surgery period.
Thank you. I would just say that obviously there's a lot to this, and your book is an excellent resource for anyone that wants to get into this.
Thank you so much.
And also, I want to ask to Dr. Bradley. Dr. Choi said now it's about 70 or 75% of total patient can get a surgery first approach. How about you? How is your experience?
Not quite as high percentage. However, we eliminate, just like Dr. Choi, the cleft patients we don't do. If we need dental extractions, no. But majority of our patients, it's a little different population in South Korea. We see a lot of class 3 malocclusion, and for those patients, yes. So I would say it's probably about 50%, close to 45-50% of patients. A few things he mentioned: the third molar extraction, that's not a big deal for us. We do it at the time of the surgery. Some of the disadvantages I don't see, but I would say we're not doing it as a high percentage, maybe about 50% now.
Yeah, that's why I expected the patient population is different. Class 3 is more common in Asians, right? Minjung, do you have any questions?
Okay, yeah, I have a question for Dr. Choi. Obviously, I would like to echo Dr. Bradley. Congratulations on your fantastic work with your team at Asan Medical Center on pioneering this technique. And the question I have is, in your experience, when you transition from the traditional method to surgery first approach, how's your patient satisfaction has been, and the compliance, how they're and kind of receptiveness of orthodontists? How have you seen the trend? How has it been?
Even the fact that traditional orthodontic approach required at least 6 or 12 or sometimes 18 months of pre-surgical orthodontic treatment, the patient compliance generally looks very good. Actually, the risk exists. So that would be one of the reasons many Western orthodontists or the craniofacial surgeon would be reluctant to apply the surgery first approach. But if you predict possible immediate occlusion, your orthodontist will be able to decide surgery first could be applicable or not.
Okay, I have one more question. I think the teamwork and good communication with the orthodontist is a key for the successful this surgery. I think there's a lot of plastic surgeons just starting the orthodontic surgery and want to build a solid teamwork with orthodontists. Do you have any advice?
Probably the many craniofacial surgeons cooperate with at least 3 or 4 orthodontists. You should sacrifice some time to communicate with them. Inevitable time for the patients and develop team spirits. Always I try to have more time with our team. That's my solution.
So even for the surgery first approach, you refer the patient before the surgery all the time?
Yeah, always. And then I'm using actively the SNS, Kakao Talk, or anything. So frequent talks. So SNS is really important the tool in modern.
How about you, Dr. Bradley?
I completely agree. I think the relationship is so important. And I think if you're starting out, once you have a good relationship with an orthodontist, they'll trust you because a lot of times the surgeon is guiding them to something they haven't done before. Surgery first is a change in their thinking, their treatment. So, but once they trust you as a surgeon, they'll be more apt to do that. We have a dedicated email just for orthodontists, a nurse that takes all the questions, and we do a lot of virtual calls with them, Zoom calls in preparation. But yes, we always involve the orthodontist. And I think in starting out, once your relationship is strong with the orthodontist, they'll be more want to try something new like this.
I see. So Dr. Choi, earlier you mentioned you're using virtual planning. Do you have experience to use the 3D printed like plate or something?
It could be applicable in South Korea, but the problem is cost, too expensive. So actually, I didn't apply for my patient yet. Yeah, but to my understanding, in US, the 3D printed or the prevent the plate is very popular. Is it right, Jim?
Yes, very popular, the plates and planning, even doing, I still use surgical splints as a backup, but you can, with the cutting guides and the plates, you really don't need them. I just do it kind of for teaching and for backup. But the custom plates, which are not just pre-bent, but like molded, is very popular now.
Yeah. So actually, since the 2014, I'm actively using the computer simulation, but 3D printed the titanium plate, actually the cost is too high. That's the problem.
Yeah, here they wrap it into all the surgical costs as a process. I think they wanted to do that to make it more cost effective. And I just want to clarify, yeah, when we do virtual planning, that's for the surgery, but I think what Dr. Choi is talking about is the simulation of from the surgical first process, separating each tooth. There is no good software now to do that. And I guess if you guys want to forward that, that would be a huge benefit to all of us.
Wow. So let's communicate more frequently, Jim. Yeah.
Okay. Sounds
Yeah.
perfect.
Yeah. So when I visited the UCLA in 2003, I observed your operation as a resident. It is a really huge honor to discuss with you online.
Likewise, when I visited you, I was very impressed at your center, obviously, and what you've accomplished. So I was happy to see how your career has progressed quickly and how you've taken things like this on and really made an impact on our field. So congratulations again. It's wonderful to collaborate with you.
When did you publish your book?
Last February.
Oh, it is recent.
Yeah, really brand new.
I need to get your side
Yeah.
of the book.
So
Thank you so much for joining Heart of the Press. Dr. Choi, congrats on your book publication. And it's our honor to have you for the Heart of the Press.
thank you so much, James.
Of course. Hope I see you soon.
Thank you very much for joining this fantastic discussion. Be sure to tune in for other articles we'll be discussing on future Heart of the Press. You can also connect to the Global Plastic Surgery Society through our YouTube channel, Facebook, Instagram, and Twitter. We are looking forward to meeting you on our APS social media. Let's be social, but distant.